Hello class, and welcome to week 2. I'm your instructor Mark Harvey, and I wanted to do a quick little video to help you prepare psychologically for the quiz. I know that quizzes can be very stressful. I just took a quiz last night for 2 hours in one of my classes. It was grueling. My head thought it was going to explode. I'm still tired thinking about it. So anyway, quizzes are stressful. Your reading is, we did a real good job of paring down the amount of reading. So as long as you kind of are able to skim through all of the reading, you should be able to cover it. I know you have other classes and things, but we tried to make it manageable anyway. Okay, so I'm gonna talk about some things that will probably show up on the quiz. But first, book recommendations. The Psychiatric Interview by Daniel Carlat. This book is packed full of great stuff. It doesn't really matter what field you're going to work in, after you graduate. You could use this in the emergency room, you could use this in primary care, you can use this in the nursing home, you can use it with kids. There's just a ton of great information. He gives you concrete ways to ask difficult questions. Like he covers how to ask somebody if they're suicidal, or how to ask somebody if they're hearing voices, things like that. I found this very interesting. I was just reading the book today, and I'll have you know, I had a PA student, not that we're competing with PAs, but my PA student read this book twice in one night. That's how good it is. So anyway, I gave it to her. She brought it back the next day and like, okay, here's your book back. I'm like, oh, are you sure you don't want to finish reading it? I'm like, no, I read it twice already. Okay, anyway. So the Folstein MMSE, the Mini Mental Status Examination, or Mini Mental State Examination, has come under some debate recently about how good it is. It's super, according to this, it is super sensitive, meaning you're unlikely to miss cases of dementia. However, the specificity is low. I don't know how to say that. Anyway, meaning that many patients who are cognitively healthy might be misclassified as demented. This happened in 17% of patients in one study. So that's very interesting. The MMSE, that might be on the quiz. No, I shouldn't say that. That's too easy. Okay, anyway, the mini mental status. You should practice doing a mini mental status exam. It's really fun. Okay, what else is in this book? Siggy caps. There's a ton of mnemonics, ways to remember things. And as he says, unless stated otherwise, these mnemonics are the products of my own disordered brain. Okay, so trying to bring order to your interview. Siggy caps is for major depression. SIGECAPS. Sleep disorder, interest deficit, or anhedonia. You just don't care about anything. Guilt, which includes worthlessness, hopelessness, or regret. Energy deficit, just being tired all the time. Concentration deficit. Appetite disorder, either decreased or increased. Psychomotor retardation or agitation. Like, you can say, do people say that you're moving slowly? Or do you feel like you're moving slowly? And suicidality. So major depression, Siggy caps, that's a mnemonic to help you remember to ask the different components of major depression. There's a ton of them. There's Dig Fast, which is for mania. That's a great distractibility, indiscretion, grandiosity, flight of ideas, activity, increased sleep deficit, like not needing to sleep, talkativeness. So that's Dig Fast. There's just a Anyway, get this book. You should get it. Now, another book that you should have in your nurse practitioner arsenal, no matter where you're going to be practicing, is the DSM-5. Now, I'm not recommending the big DSM-5, which I have like 3 copies of, but I'm recommending this little jewel here called Desk Reference to the Diagnostic Criteria from DSM-5. Spiral bound is my favorite. I have a couple psychiatrist friends who always come into my office and borrow this off my desk. You know, once you've read the whole DSM-5, you don't need to reread all of it. You just need to, okay, you know, look up diagnostic criteria for whatever. This is how you make a diagnosis, which is how you get paid, by the way. You have to have a diagnostic code. Okay, we can debate about whether that's a cool way to structure medicine or not, but anyway, you have to have a diagnostic code in order to bill and get paid for your services. You also have to have a diagnostic code attached to your prescription. So if you're treating major depression or major depressive disorder, as it is in the DSM-5, you need to document clearly that the medication you're using is for that diagnosis. And you should document if it's FDA approved for that diagnosis or not. Because a lot of medication, for example, a heroic measure, they call it, is to use a stimulant for treatment-resistant depression. So I have a guy with severe treatment-resistant depression, and he's on Vyvanse as one of his many medications that we're trying to help his treatment-resistant depression with. Anyway, it's totally off-label, so you need to put that in your note saying this is not FDA-approved medication for this diagnosis. However, we're using it for major depressive disorder. And in your note, if you're going to make a psychiatric diagnosis, you need to have the DSM-5 criteria in your note somewhere to support that diagnosis. For example, some of the most difficult diagnoses to make are the personality disorders, I feel like. And so you really need the DSM-5 criteria in your note to prove that diagnosis. Okay, so those 2 books, I just gave you a ton of quiz questions. A couple other questions. Have you heard of countertransference? It's not just something that happens in psychiatry, it happens in every field of nursing and medicine. When you project onto a client your own feelings. For example, this happens when someone commits a crime such as sexual assault or sexual harassment. Sometimes, I'm just getting theoretical here, a person in a place of power sees the other person as desiring them, like they're projecting onto that person, and that person has no interest whatsoever and maybe has said so, but the harasser has countertransference. They put their thoughts into that person's head. So this happens if you were criticized a lot as a child and you have some trauma from that. You may not take criticism very well, and so you may see other people as critical, even if they're really not. So anyway, that's some countertransference. I've got the entire quiz right here, so I'm just going through some. Did you know one of my passions is preventing child abuse, and I was a child abuse medical examiner for a while. Did you know that child abuse is not covered under HIPAA? And I've ran into this problem numerous times where a provider, a nurse, an MD, a pediatrician even sometimes will say, well, I can't disclose that abuse because of privacy. No, if someone tells you that they're being abused, discloses abuse to you, you do not need a signed permission slip from their parent to report it. And in fact, you're legally and ethically and morally expected to report child abuse. Okay, so that's not covered by HIPAA. You know, the same is true in psychiatry. If someone comes into the clinic, I can't remember what it's called. There's some law in California where if a patient says, I'm planning to kill someone else, like we're required to notify the police, of course, or law enforcement, and also to notify the person that they're planning to kill. So that's interesting. Anyway, so HIPAA, you know, obviously, if the person tells me that they're planning to kill their spouse, for example, you know, reporting that to law enforcement and to the spouse is not something that you need to worry about confidentiality about. Okay. I hope that I don't have to do that. I mean, I do the child abuse thing all the time, but the call the spouse and say, look, so-and-so says they're going to kill you. Anyway. Okay, we talked about the DSM-5. We talked about the MMSE. Now, I had a patient. How long is this video going? Okay, I'm like at 11 minutes. I'm going to keep talking. I had a patient last week who is frail. I would say frail because she keeps falling. She's 78 years old. She's been really confused in the last 6 months to a year. Sleeping 22 hours a day. Been admitted to the hospital on several occasions for constipation. And came to my psychiatry clinic for her severe depression because she's crying all the time also. Well, turns out she's on amitriptyline at a very high dose. And taking it twice a day. I use amitriptyline sometimes at a very low dose to help people with sleep. I mean, it's a tricyclic antidepressant, so it helps with depression, but it's got so many anticholinergic side effects of constipation, sleep, confusion, you know, drowsiness. It's not very useful at high doses. If I was going to start an elderly patient or a frail person on a new psychotropic medication, a good practice is to start slow and low. How do you say it? Start low, go slow. Yeah. So, you know, if I normally start people at 10 milligrams of Lexapro, then I would start a frail elderly person on 5 milligrams of Lexapro, like half the dose. And if I was going to start somebody on amitriptyline, which I have started a few older adults on amitriptyline, I would start at a baby dose, like 6.25 or something. Like they would have to chop the pill in 4 pieces, you know, to get that tiny dose. So this patient that came in last week was on 50 milligrams twice a day. Like, no wonder she's constipated, no wonder she's sleeping 22 hours of the day, and no wonder she's confused. Like, come on, people. Anyway. And, you know, she fell on her way into the clinic in my parking lot. Even though her husband was trying to hold on to her. And that's like, anytime somebody falls, you should ask yourself which moron prescribed the medication that caused this patient to fall. That's what you should ask. So anyway, not always the case, of course. I mean, you know, but a perfect example is orthostatic hypotension. You know, cardiology loves to load you up on beta blockers after you had an MI, and I remember always recovering post-MI patients. We started them on their carvedilol, and it was at a pretty high dose, and the patient could not raise their head or sit up on the edge of the bed because they would get so dizzy with their orthostatic hypotension. So that could be a quiz question. What else is on the quiz? Well, there's always a big discussion and fear about pregnancy and psychotropic medications. And a kind of general rule is the illness sometimes can be worse for the baby than the medication. So if there's like a severe bipolar that's going to go totally manic without their medication, then you may want to keep them on a medication. There's a few medications that have a serious like contraindication, cause fetal harm and birth defects. But most of our antidepressants, like our Lexapro, SSRIs, we haven't really documented that they cause birth defects, but we do worry about the baby after he or she is born going through withdrawal from the medication. So, like say you're taking Effexor and you quit Effexor, the withdrawal effects of Effexor make you think you're dying. Same with Paxil. You feel like you're dying when you stop taking it. Well, if the baby's going through withdrawal, they're going to have a crappy first couple days of life after they're born. So other things to think about is the medication going to sedate the baby? So is mama on high dose of Seroquel and the baby's going to be super flaccid and sleepy when he or she is born? Anyway, things to think about. I think if you read the signed reading, you're going to do great on the quiz. Quizzes are stressful, I know. We can do some debriefing afterwards. If you have questions leading up to it, send me an email. And anyway, I think I covered everything that you need to know for week 2.